So my name is Steph. I'm one of the organ donation nurses for UHL, and this is Liz as well. On the 1st of January, they updated the neurological death test forms with some new guidance, and we just wanted to share the changes with you. The changes came from FICM. It wasn't anything to do with NHSBT, but generally we do have a invested interest in NDTs, so we are sharing the learning. So I will play a video first, which is from Dale Gardner, who headed up the working group.
My name is Dale Gardner. I'll be taking you through the new testing form for the diagnosis of death using neurological criteria. From the 1st of January 2025, we'll all have to be using this new testing form on our intensive care units. This is to coincide with the Academy of Medical Royal College's update of the old 2008 Code of Practice into our new 2025 update of a Code of Practice for the diagnosis and confirmation of death. If you want to know more detail about the justifications and reasons for the updated changes in the Code of Practice, it's best probably just to go back and read for yourself. But just to highlight before we go on to the testing form, the major updates are in the age categories, and the form we'll be talking about can be used in 2 years and older, changes to the apnea test, and changes to the time of death, where we're timing it to the second set of clinical tests. You also see there's, in keeping with those changes, greater alignment with the rest of the world. We're moving towards a temperature of 36 degrees Celsius and the need to be able to examine both eyes and both ears. There are some other clarifications on who can test. Those familiar with the old endorsed testing forms and the 8 red flags will see that they're now fully incorporated into the preconditions. More explicit guidance on peripheral nerve stimulator. A change from the minimum sodium from 115 to 125, and an expanded section on ancillary investigation with guidance. So the first thing you may notice on this form is it's blue. The old forms were purple in colour, and the changes may need to ensure that people recognise that they're now onto a different form. There's no longer a long or short form, there's just one form, which is 8 pages. As I've said before, this form can be used for 2 years of age and older. There's a different form, a yellow form, for neonates and infants. As you go through, you'll see that the guidance and what paragraph it is in the code is really clearly and explicit. So if you ever need more information, you can see in the code where you can find it. There's greater incorporation of ancillary investigations. There's an expansion in the time of death section. And the question flow of answers for someone who is confirmed deceased using neurological criteria is in the preconditions, it's yes. In the examination, the answer expected would be no. And then when you're confirming death, the answer would be yes. And that order is just to aid readability and usability as you're going through the form from a grammatical point of view. Let's start. So page 1, it's pretty familiar. This is an endorsed testing form. There's already some endorsements, and we're hoping to get some more endorsements very soon, which will be implemented for the 1st of January 2025. For those using electronic testing forms on your hospital systems, it's important you're using the most up-to-date form. Some suggest that it's easier to actually print out this form and then transcribe to ensure you're always following the latest version of the form. When it comes to patient selection, as I've said already, in the old Code of Practice, the transition to using adult criteria for diagnosing death using neurological criteria was 2 months of age. From now on, after guidance from the Royal College of Paediatrics and Child Health, it's 2 years of age is the transition point. Some clarifications in this endorsed testing form is also in the Code of Practice, that actually it's equivalent international professional body recognised by the GMC for more than 5 years. That's very helpful for doctors who have come from overseas. Where required, 4 different doctors can make the diagnosis, but each pair of doctors must fulfil the above requirements. Clarification, the conflicts of interest, should not be acting on behalf of the organ retrieval and transplant service at that time, but does not stop clinical leads for organisation being one of those two doctors. And very importantly, and what the community is very much asked for is clarification that an intensivist or anaesthetist who diagnose death using neurological criteria can still assist in organ retrieval or in caring for patients post-transplant. Equipment section is just really an aid memoir if people are trying to work out what they need to prepare for carrying out the testing. So on to page 2, you'll see now that the preconditions in the code of practice are now like 4 major preconditions, and the first one is etiology severe enough to cause permanent cessation of brainstem function. Very similar to the old endorsed testing forms. You write down the etiology and then you write down your evidence and the neuroimaging. Other evidence here might be in height, the intracranial pressure, or some other aspect. Precondition 2 is the assessment period sufficient to exclude the potential for recovery. Those familiar with the red flags from the older endorsed testing forms will see that many of those red flags and the time periods appear here now. Precondition 3 is the exclusion of potentially reversible factors materially contributing to the coma or apnea. There is some guidance here, but if you need any more guidance, then the paragraph links to the code are given. As we start to fill out some of the questions from precondition 3, it asks, like, hypothermia is the core temperature greater than or equal to 36 degrees, and the answer has to be yes. Note that this is a change from the 2008 code where the temperature used to be 34 degrees Celsius, and this change was made by the Academy to better align the UK with our international peer nations. It does mean that we need to be watching the temperature and correcting anything under 36 degrees Celsius quite actively before we carry out testing. There is some other clarification about the need for peripheral nerve stimulator. In fact, peripheral nerve stimulator use was been present since 1976 in the very first code of practice. Moving forward, there's a second page of precondition 3 questions. One is the sodium is between 125 to 160, and you write the answer in there. This is a slight raise from the minimum sodium that was acceptable in the 2008 code of 115 millimoles per litre. And then you complete precondition 3 by answering, are you satisfied that potentially reversible factors which could be materially contributing to the coma or apnea have been considered and excluded? And ordinarily the answer would be yes. If for some reason the answer is no, then there's a need to document your mitigation, which will most often be an ancillary investigation. Precondition 4 brings out the additional caution for uncommon circumstances, and those familiar with the older endorsed testing forms and the red flags will see that the red flags from there, the ones that haven't been covered already, now appear here. These are sort of uncommon circumstances such as isolated posterior fossa or brainstem, lesions, therapeutic decompressive craniectomy, or therapeutic steroids to reduce brain edema. If you need to have any of these conditions and need more information, then the code's paragraph is linked there. If you have to answer no to any of these, as in you have the uncommon circumstances being excluded, most times you can say yes, they haven't got any of them. But if you have to say no, they actually have one of these, then you need to document your mitigation, which would normally be an ancillary investigation. So there's a whole expanded section on ancillary investigations to take account of the fact that we have more guidance from a sort of multi-professional group from 2023, and the Academy was very supportive of professional national guidance, very much feeling that they should give the principles, and it's for the professional organisations to actually give the actual specifics. And that CT angio guidance you can sort of see at the left was both a neuroradiology and an intensive care joint publication. So this is the place where you can document any of your ancillary investigations, which you may have had to use to mitigate any of the preconditions that couldn't be satisfied. On page 6, we move into the clinical testing for the absence of brainstem reflexes. The important thing to note in the new 2025 update, in the case of an inability to examine both eyes or both ears for whatever reason, ancillary investigation will be required. And this change was made by the Academy to align the UK to other international peer nations. So they ask a series of questions such as, do the pupils react to light? And in someone where death will be diagnosed and confirmed using neurological criteria, all the answers here will be no. There's a little bit of extra clarification that used to be that the pupils just had to be fixed with no mention on the size. But now the Academy is saying that pupils must be fixed in a mid-size or dilated position. But the rest of these questions are very familiar to those who have done neurological testing before. Moving on to the apnea, which has some more significant changes. And the changes are really designed to bring the UK in line with other peer nations. So going from the top there, you've got the Academy Medical Royal College 2008 code and the Royal College of Paediatrics and Child Health code from 2015 for neonates. Then you've got the World Brain Death Project from 2020, the Australian New Zealand Intensive Care Society from 2021, Canada's guidance from 2023, and the USA guidance from 2023 as well. And finally, in the blue, you've got the Academy 2025 update. And as you can sort of see as you peer across, the main international alignment is on the end CO2, not a starting CO2, but the end CO2, where many nations ask for a PaCO2 greater than 8 kilopascals with a pH less than 7.3. And this is what the Academy 2025 update now recommends. Many nations also ask for, as did the RCPCH 2015 neonatal guidance, a rise from the starting CO2 of 2.7 kilopascals. Why 2.7 kilopascals? It's 20 millimeters of mercury, and a lot of this evidence comes from North America. So then when you think about when you're going to start, if you need to get over 8 and you need to rise by 2.7, then it made logical sense to have a start at 5.3 kilopascals, because if you add 2.7 to that, you will always get over 8 kilopascals. When it comes to the time of the apnea test, the minimum of 5 minutes is very much emphasized as a minimum. Most other nations don't have any mandated time period. They more have guidance of when the CO2 may be over 8. So you don't see them say as a definite mandated period, unlike the UK. And so the Academy has stuck with a minimum of 5 minutes, but very much emphasizing this is a minimum length of time and you may need longer. The guidance of the apnea test is here. The apnea test must not be performed on mechanical ventilation. There is recognition in the code that if there is an absolute inability to carry out an apnea test, then as a mitigation, an ancillary investigation can be used. This was theoretically allowed in the 2008 code, but is a very rare circumstance. Even though now it's more explicitly allowed, I still think that it's important we keep it very rare. Example, cervical spinal cord pathology. So this is the steps required in the apnea test. The form takes you step by step through it, and to go through this now in more detail, this is what's required in relation to carbon dioxide. Firstly, a starting carbon dioxide of 5.3 kilopascals. This will hopefully be easier to achieve than the previous augmented carbon dioxide of 6 kilopascals we used to have to do under the old code. Then you need to calculate the target CO2, what you want to achieve by the end or longer of your 5 minutes. To calculate this, take your starting CO2 and add 2.7 kilopascals, because that will be the rise that's required. And then when you actually finish your apnea test, you have to ensure that the end CO2 is greater than or equal to this target CO2. Let's give an example. So working through an example, we starting at 5.61, we add 2.7 using a calculator, and that is 8.31. That's our target. We wait for the CO2 to come back at the end of the apnea test, 8.85. It exceeds our target CO2. This is a correctly performed apnea test. Doing it again, we're starting at 6.53 this time, adding 2.7, 9.23, and then we wait for the CO2 to come back. It comes back at 9.25, which exceeds the target, another correctly performed apnea test. It is really important we concentrate very carefully in this, use a calculator to ensure our numbers okay, get someone else to double check, and make sure we do this correctly every time. As well as the CO2 goals, there is also some pH goals, which requires an arterial pH less than 7.3 or a H plus greater than 50 nanomoles per litre. It's where we document the end time of the apnea test. Now, it's very important we understand what the minimum 5 minutes is. So it is definitely a minimum, because when you look at the rise of the CO2, you could expect it to rise around half a kilopascal per minute. So 5 minutes times 0.5 kilopascals is a rise of around only 2.5 kilopascals, which doesn't meet our 2.7 threshold. So it's important, it's a minimum. So what are our options? One is you could take a sample at 5 minutes, but you have to have a reasonable expectation. You may have to repeat the blood gas immediately when you see that result, because it won't have got to 2.7 and reached your target CO2 that you're waiting for. The other option is to, patient is stable, is just to delay taking the sample to around the 7 or 8 minutes, because you're much more likely to have risen to the 2.7 threshold and reached your target CO2. And this is where we document the conclusion of the apnea test. Now it comes to the final page, which is the completion of the diagnosis. Here, you write down a register of the doctors carrying out the diagnosis, test 1, Dr. 1 and 2, and test 2, Dr. 1 and 2. The Academy is very clear that deaths confirmed at the time when all doctors involved in carrying out the clinical tests are satisfied all the relevant neurological criteria to diagnose death are met. And this would ordinarily be at the time of completion of the second set of clinical tests, and this becomes the time of death. If ancillary investigations are required to confirm death, then it's once those results are known with the clinical criteria being satisfied, that is the time. So this responsibility falls upon the final 2 doctors in test 2. So that was a run through the new testing form, which will correspond and something we all must be using from the 1st of January 2025 with the Academy of Medical Rural College's Code of Practice for the Diagnosis and Confirmation of Death update.
There we go. Any questions?
Have you seen it yet, Steph?
The new form being done? No.
Yeah. I was just wondering how long it takes for the CO2 to rise far enough.
I'll let you know.
We would commonly stop the patient back on the ventilator at 5 minutes.
No, I don't. I quite often leave it. So I don't. I wait till the gases come back. If they're not desaturating. I've never done it when they are desaturating, so I just leave it till they come back, just in case it's not high enough.
I think that needs to change my practice, because we might not be able to rise if we're not careful.
I think that is more the normal practice that I've seen, Zoe, is if the patient is stable, just leaving them on the bag until you get that confirmation.
It always was high enough, because you're only going by 0.5. 5 minutes was more than enough for that, but
I think it's just highlighting that it might not be enough, and before it was 5 minutes and that's it. Now it's the rise rather than the time.
Yeah.
Jenny? I've done the ancillary investigations, if we can run all the application.
Yeah. What are they? Yeah. It's mostly CT angiography, or sometimes EEG.
Usually CTA, yeah.
We are doing a session at the beginning of February on ancillary testing, particularly because we had one that didn't go, that I had to do twice last month because the radiologists aren't used to doing it either, because it's very specific protocols as to what they, about timing of contrast and dual or triple phase scanning.
Yeah.
Triple phase scanning, I think, wasn't it?
And it's in terms of what we request, what the radiology protocol is, and then some specific wording that has to be in the report.
Yeah.
For it to be valid, so it's from all sides, it's really quite specific, and we don't do it that often, so we thought it would be useful to cover as a session in February.
Yep. Any other questions? Oh, Jenny, you've got your hand up.
I think it's a shame that we've struggled with that patient last month, because I gather the person that's been involved in writing the radiology guidance is actually from Leicester, which is interesting.
And he's been in teaching.
Brilliant, excellent. Let's hope we get better outcome next time. My question, Steph, really was about, obviously we need to be able to be clear that, oops, sorry, both eyes and both ears are examinable. Sometimes people forget to tell us about, you know, their loved one's false eye and whatnot. Should we be asking more questions about this? And also, if we do subsequently find out the patient had got one glass eye, does that make the diagnosis unsafe?
I mean, I would hope that as a bedside nurse, I would be checking both eyes as normal practice, and would maybe find that out before we get to this point. You can still do the testing with one eye, that's fine, but the advice now is, well, the guidance is you have to have ancillary testing, whereas before it was suggested that you have ancillary testing. I think that's the biggest part, but you can, with ancillary testing, even if you can't do one of the tests, you can still say that they are neurologically dead, if you have the supporting evidence as well.
We probably need to be a bit more curious, don't we? As doctors, we probably need to be a bit more curious.
Absolutely. And I mean, the other thing with that I've kind of thought about with these new changes is the fact that the temperature, it needs to be 36 degrees for 24 hours before testing. So it's not, if you have, they say if you have like a sporadic reduction, so you drop your temperature for a couple of hours, that's fine. But if it's like 6 hours of being below, then you need to start the clock again for the 24-hour period. So I think more careful preparation for these tests is probably going to need to maybe be thought out the day before or whatever, in actual planning and things.
Yeah, because the patients that are brainstem dead tend to lose their hypothalamus control and get quite cold.
Absolutely, they do.
I guess we might have to use the bear hugger, or not bear hugger, what do I mean? Arctic sun, potentially.
Yeah. But again, it's that preparation side of it, you know. Phosphate is another one that we see a lot.
Phosphate's always been annoying.
And again, that takes 12 hours to replace. So, you know, it's just looking the day ahead at all of those different things, looking in the ears, making sure you can see the eardrums, you know, and things like that. It's just maybe a thoughtful change in practice more than anything.
It's the traumatic ones that have got big black eyes that are all swollen and you can't open their eye, that's problematic sometimes.
Absolutely. Sorry.
As new guidance, they would potentially be getting CT angio really, really tight.
Yeah.
Yeah. And what Dale has said is, with changes in these different parameters, is that he's very available for questions. So he normally gets a question about death testing maybe once every couple of weeks, but he's literally said you can call me anytime, you know, and made it very clear that he wants to help kind of ease into this new form as smoothly as possible.
That was a nice guy.
Yeah.
He works in Nottingham.
Yeah, and that's it. Any other questions?
Any questions?
Thank you.
Not from
Thanks
here.
very much.
Thank you, guys.